place their name on the whiteboard so that you can see which ones are here tonight. Some of them are from Edmonton, some are from our own community, regional health hospital here, and some are from, I believe, Athabasca. Where are you from, Stacy?
I'm from Morinville area.
Morinville area. So there's a diverse crew here, and they're all here to answer questions about doctor recruitment. Now, if you look at the agenda, it says doctor retention, but it's actually recruitment. And the reason that we called this meeting was to discuss the recruitment process. But before I begin and let them have the floor on recruitment, could we ask that your cell phones be turned off? And housekeeping, there's bathrooms just outside the door to the left and the right. The structure of the meeting will be, we're going to discuss the process for recruitment. And that was an education process that the councils of both Big Lakes and the town of High Prairie have asked the Alberta Health Services come and let us know or tell us how do doctors get recruited to this community and what the parameters are, what the barriers are, what the constraints are, and what the opportunities are. So we're looking to discuss recruitment here. At the end of the meeting, when we finish the recruitment educational process, then Dr. Worry and his team are here to answer general questions from the gallery. So they may not be able to answer completely your questions because the experts they have brought are just here to discuss recruitment. But if they can answer your question, they'll attempt it. Otherwise, they would ask that you go to see Nancy Tanscowney, our executive assistant, leave your name and a gist about what your question was, and they will get back to you with an answer that hopefully will explain what the answer to your question. And I will reiterate this portion of the meeting once I close it, because we are also asking that if you do have a question from the gallery, that you go to the microphone that's sitting there so that everybody can hear you. The acoustics in this room are not good, so we cannot hear most of the time when people are standing from the gallery. And we will ensure that the people at the table here and that the people from Alberta Health Services use their microphone, because the meeting is being recorded. For those that can't attend or couldn't attend or did not realize we were having a meeting on this subject, it will be placed on the website, on the town's website, within about 4 days. So you can then go back to the website or let people know that the town's website contains the body of the meeting portion of it. So if we have no other questions, then I will call this meeting to order. And could I have a motion then to adopt the agenda? Councillor Panasic has made the motion to adopt the agenda. And all in favor? It's carried. I would also like to thank the County of Big Lakes councillors who are in attendance, because it's good when we sit together and we hear we're on the same page then, and we know what's happening in our community. We also, I will put another plug in for our joint meetings. We actually have had a few joint meetings, and we have arrived at a good consensus as to how we're going to move forward on some other topics that impact the whole community. So I'd like to, I should start with introductions, because some of you probably do not know the people at the table here, plus the Alberta Health Services representatives. So I'm going to start with Councillor Gilroy. We'll go around our table first, and then we will ask that Alberta Health Services introduce yourselves. Please use your microphone.
Okay, Councillor Brian Gilroy, Town of High Prairie, one of the newest ones. You can use that one.
Ann Stewart, County Councillor.
Arlen Corley, Town of High Prairie Councillor.
Brian Panasic, Town of High Prairie Councillor.
Ken Matthews, Reeve, Big Lakes County.
Linda Cox, Mayor, Town of High Prairie.
Donna Danaka, Councillor, Town of High Prairie.
Debbie Rose, Councillor, Town of High Prairie.
Hi, Dr. Richard Ibach, Acting Associate Zone Medical Director for High Prairie and Deputy Zone Medical Director, North Zone.
Stacy Greening, Senior Operating Officer for Zone-Wide Programs and Performance for North Zone.
And Kevin Worry, I'm the Zone Medical Director in the North. Do you mind, Lyndon, could we introduce a couple of our colleagues just to the back here that are up? So if people can hear me okay, so we've got, I think most people know our Director, Roxanne, that covers all of Area 6.
Do you want to stand? Thank you.
Great. And Dr. Dutois, so one of our local docs and also our Community Medical Director here in High Prairie. We've got Rhonda here as well, who works in our Community Health and Wellness Clinic. We've got Dr. Niazi, who is our new Medical Director in the Community Health and Wellness Clinic. And we've got Doctor, she'd like that. Maybe we'd like to avoid it. Deb Whetstone, who's here as our Manager of Physician Resource Planning for our North Zone. And I don't know if everybody knows Trina as well. So Trina Noski works in our primary care team. And John, I apologize, we don't know each other all that well, so I'll make the intro. Could you tell the room basically the field you cover as well, sir?
I'm the new care manager for acute care and emergency.
Fantastic. And I wasn't sure, Linda, if you wanted, because we also have our colleagues from the High Prairie Medical Clinic, right, with Dr. Edwards and Dr. Laughlin and their team here.
Yes, I was going to ask them
Great,
also.
thank you.
Could Ms. Johnston, could you introduce your co-workers?
Yes,
Dr.
we have Nancy Starko, Dr. Pamela Edwards, and Dr. Robin Laughlin, and myself, Judy Johnston.
Okay. And of course, the gallery is here to participate at the end of the meeting. Okay, so now that we've had the introductions and we have a scheduled delegation, and we're going to talk the process of recruitment. So you have the floor.
All right, let's see if people can hear me okay here. Trust people can hear me okay? All right. So maybe what I'll do with that introduction, Mayor Cox, and once again, thanks for the opportunity on behalf of Alberta Health Services to come and actually chat with both councils as well as our High Prairie community. There's a number of questions that come up in most of our communities as to how physician recruitment, how it actually works. It isn't always a simple process. We'll try to provide a broad overview, but because there's multiple different stakeholders involved, from Alberta Health to the College of Physicians and Surgeons to Service Canada, so there's a lot of different regulations that can be part of it. I'll try to provide a broad overview, so it's it's the general approach that we would take. And perhaps something that will help, just as we discuss the overview of how we actually develop bringing a physician to a community. It all starts really with our workforce planning, and that's usually the first step. And certainly as you're looking at any of your workforce planning, that has to be linked obviously to your health service plan. So you have to decide really what are the types of services that you need to be able to offer to go ahead and meet the healthcare needs of a particular area. Some of the things that we would look at early on in a community like High Prairie is again, in broad strokes, we would look at the population of the community and the surrounding areas, really the catchment population as well as the town and the MD itself. We would be, then from that, we'd be looking at in connecting in with different parts of Alberta Health and different parts of Alberta Health Services, what do we see as the common diseases that we need to be able to manage? So quite commonly in the north, for example, we'd have to go ahead and have a team that can manage cardiovascular disease, can manage what happens when people run in with cancer, or we want to be able to take actions to prevent people from getting cancer. The management of endocrine disorders is typically number 3, so diabetes would be the most common. And number 4 would typically be COPD. So again, broad strokes, you're looking at how many people do you have to look after. You're looking at what typically, when you're looking at what the team would look like, well, what sort of conditions are you going to have to treat? And the conditions you're going to have to treat are related to those underlying diseases that I've just described. So cardiovascular issues, for example, would be heart attacks, strokes. Those would be examples of some of the conditions you'd run into. We then specifically have to look at the type of community in which you'd be offering services. So High Prairie, as we've discussed here before, is a co-hub. So it's something that in Area 6 in the north is really a center, not as a smaller rural community, but as a center that brings in specialty services as well. And we have people that specifically come to High Prairie to go ahead and receive services. And that again influences that's reflected in the health service plan. And that's reflected in the workforce plan that we come up with as well. If I jump specifically to how we build physician components, and I'll have to come back with a little bit of a fill out on this topic later. But if we would jump more directly, given the nature of the question on physician coverage, from there typically what we would look at is what are you going to need for any sort of subspecialty coverage. So, for example, given our planning here in High Prairie, we specifically knew that we needed to bring in a physician that could actually manage, when we look at obstetrics and planning for obstetrics, someone that can actually pull out a baby. So you need someone that can actually manage C-sections, and you need to be able to also have someone that can actually manage anesthetics. So typically that nomenclature would be a GPA, or a general practitioner with anesthesia. So those are some of the subspecialty pieces you need as you're looking at, okay, well, what would the team look like when you're looking at how you actually move through recruitment? Key pieces as well, and it was fundamental here in High Prairie, is what would you really need for your ED coverage? So what would you need to cover your emergency department? And I think everyone in the room knows that we ran into a real crunch in around 2013-14, where we had significant challenges in actually sustaining our emergency services here in High Prairie. A community of this size, again, as a co-hub, really you'd have to have probably about 6 physicians that would be a regular part of that emergency department roster. And that way you actually have the opportunity to manage holidays, sick pieces, other things. So in general, you wouldn't really be looking at your physicians typically doing on an ongoing basis, unless they so choose, more than about 1 in 4 call. And so that's ballpark where that number of 1 in 6 comes from. Again, in smaller communities, you wouldn't need as many physicians for that sort of piece. So overall, with those sort of numbers in a High Prairie example, again, you'd be looking at ballpark 8 physicians is what you'd be looking at as a core as we move forward with pieces. Beyond that, what you'd also be looking at is, when you're figuring, okay, that's ballpark what we think we're going to need, you also have to factor in over what period of time you'd be looking to bring physicians in, because physicians function as part of an overall healthcare team. But it also takes time. It also takes physicians time for them to actually build up a practice and to actually have something that they can sustain. Because what, again, we'd want to avoid is, heavy physician turnover. And again, we've seen that in High Prairie previously. So when we were looking at things back in, 2014, we'd seen 9 physicians leave High Prairie in the previous 5 years. So it was heavy turnover at a time that we still had, when we look at health service planning and our need to treat particular conditions or diseases, we have the 4th highest chronic disease burden in all of Alberta. That's sizable. That's very sizable. And that's something that we have not seen significant improvements in over periods of time. So again, that goes into overall with physicians, but in overall health service planning, what would we need to go ahead and provide a better level of care to the people in a community? When we look then at, okay, ballpark, we're looking at, X number of physicians. Again, in starting, when we really looked at a co-hub of High Prairie size, you really look starting at 4 for your ED and you move up over time. But as you look at things, you end up taking input from your local physician leadership team, from your local physicians. That sort of input then typically moves up into the associate zone medical director, so the senior physician leader for an area, and input through the medical staff bylaws. And this process is all laid out in our medical staff bylaws. So if I can digress a bit here, all physicians that work in an AHS facility are required to actually follow the medical staff bylaws. And this is basically a set of rules and codes by which we agree as, independent practitioners. So typically as independent practitioners, but as physicians to go ahead and conduct themselves, but also as AHS, we have commitments through the medical staff bylaws as well. And there's a mutually agreed upon process laid out in the medical staff bylaws when it actually comes to physician recruitment and how physician recruitment works. So as you take input from local group, it actually gets fed into what's called a zone clinical department. And what a zone clinical department is you'd hear about medical departments. So family medicine, for example, is a medical department. And so when you take input from your local team, you have larger zonal teams. You have people that come together and they have an overall department of family medicine in rural areas in the north. And so input comes from a local team up to the larger group that then again looks at the input from the local team. They make a recommendation. Again, these are all the challenging steps through the bylaws, but they make a recommendation to our zone medical administrative committee, and that typically forms the basis of a workforce plan. The zone medical administrative committee is formed of the different zone clinical department heads. So those are the physician leaders who are appointed by AHS that lead different departments like surgery, like anesthesia, like rural family medicine, as well as our zone medical staff association reps. And so that's the, typically, and it can be elected, those are typically physicians that indicate that they want to represent the interests of frontline docs. And so that's where there's a combination of representation that forms that zone medical administrative committee. So again, local input to a department team, to the larger medical administrative committee that makes a recommendation for forming that workforce plan. From a workforce plan, when you identify, okay, you have indicated you need a particular number of physicians or you need a physician, with changes in how things have played out through the College of Physicians and Surgeons of Alberta. So that's the regulatory body in Alberta that governs, all physician activities. Alberta Health Services, in working with the college, has actually set up a website. So it's called drjobsalberta.com. And so any positions that are going to be available for filling in a community are posted on drjobsalberta.com. And that's meant to be a transparent way in which anyone can look in, because it's right on the internet, and you can look in and see, oh, okay, there is a position that is needed in High Prairie. There is a position needed, as a family doc, for example, or there is a need for a general surgeon in Fort McMurray. And then individual physicians can apply for particular positions. Physicians applying typically come in one of two groups. These are physicians that are already fully licensed by the College of Physicians and Surgeons. So you can't work in Alberta as a physician without a license from the College of Physicians and Surgeons of Alberta. Some people that have not been trained in Canada, so they're often known as international medical graduates, would not inherently automatically qualify for a full license. And the college has set particular standards as to what their expectations are in evaluating people that would apply through Dr. Jobs Alberta, but do not actually have that full license. So for example, if you do have a full license, can you work in a community clinic without any oversight from Alberta Health Services or any support from Alberta Health Services? Yes. Right? If, however, you do not have a full license, so you've not had an evaluation to judge that the quality of your care or your skill set, your management of resources, need for those resources has actually been evaluated, and it's the college that actually does the evaluation, then no, there's additional steps that have to be taken. So in May 2015, the college took the step that all physicians that were not fully licensed, like an international medical graduate, would require, in order to actually have an assessment done with the college, they would require sponsorship from Alberta Health Services. And they wanted to make sure that any physician coming in was actually going to be, again, they were going to be needed based on the workforce plan. And that was one of the reasons why, from the beginning, I tried to lay out what are the broad strokes of some of the things that we look at in a workforce plan. So when a physician, is actually successfully recruited to a community, then that physician actually in North Zone has an opportunity to choose, well, where do I want to work? So do I want to work in Clinic A? Do I want to work in Clinic B? And from the Regional Health Authority's perspective, it doesn't matter to us where physicians choose to work. That's a business decision. There's some decisions that are healthcare decisions, and there are other decisions that are business decision. That's a private physician business decision as to where they would like to work. And so the process that we have in our North Zone is we actually insist that physicians that do come in actually see any of the clinic options that are available, so they can actually choose where they would like to work. Pardon me, because that is very much their choice. Where this, again, I've mentioned the physician coverage piece. The one piece, again, that I would want to highlight is regardless of where a physician may choose to practice for business reasons, we would want to be clear from an AHS perspective, all of the interprofessional services to support patients and families, that doctor looks after would have access. They would have equal access to those services regardless of where a physician actually chooses to work. So if you chose to work in Clinic A or B or anything else, patients and families would not be restricted in their ability to access different interprofessional services that are available in the community. So I would paint that as a broad stroke of some of the things. There's many other factors that we have to weigh in. Again, there's an influence of Service Canada. There's an influence, so they have significant legal requirements for us when it's how do we manage temporary foreign workers, so people that are coming in, that are not fully licensed, so they're coming in from different countries, and there's quite an intricate process that we have to work through that way. We also look at times when we look at our overall planning, we don't actually need a physician to live in a particular community. There's times where based on the needs, so based on population, and we look at data, so how many visits for a particular service were required over the last several years. It may be that what we need is we need a visiting physician. We need a physician to come up intermittently to go ahead and provide service. But that service is best provided in person. That's also something that you would see, as part of what we work through in a workforce plan. And additionally, there's a provision where it comes into telehealth. So we've got other services where it either may not be efficient for someone to actually come up in person, or it may not be needed in person, but we want to make sure that our rural and remote communities actually still have access to some of those key physician services. So some of them are physicians. Sometimes we need physicians living locally. Sometimes we need physicians to come visit on a regular basis to provide support. Sometimes we need physicians that would provide support by telehealth. So again, by broad overview, population, type of community, type of disease, and then again, from that, you're looking at, okay, what broad scopes of coverage would you need? Specialty services, ED coverage, and that often provides what's your rough outline of how many physicians you would need. And then there's a whole process that you go through as far as gathering input and seeing how that, and it's gathering input from multiple different areas, not just at the local area, but from zonal departments. And again, then it's linked to how does the physician actually apply online? And does the physician have a full license or not have a full license? And that's the broader stroke of how physician recruitment works.
Does anyone else want to add anything?
So Deb in
from your
particular
team?
has to live this every day as our manager for physician resource planning. So just ask Deb, is there anything from that you'd want to be able to build on in particular?
No, I think you've covered it all. Like Kevin said, every spring we do ushering me to the front. So like Kevin said, every spring we do a workforce planning analysis. We use a lot of resources to gather the information that we do have. And I do have a sample here of some of the things that we go through. Like Kevin said, we look at the population, we look at the ED visits every year, we look at the occupancy rate, we look at interprofessional care that's offered within the community. We look at third next available appointments. That's appointments available to get in to see physicians. If I call today and I want to get in for an appointment and I can get in today, I ask for what the next appointment is, and then I ask for what the third appointment is. It gives me just a general idea of an average of what the appointment time is. We also look at the core services that are offered and how many people from those requiring those services are sent out to other areas like Edmonton and Calgary. And it's very hard to get an accurate account on those services that are out because we run reports based on postal code. However, if Kevin is from High Prairie and he's in Edmonton and he has a heart attack and he has to go to a hospital in Edmonton, that's not us referring him out, that's him having to seek a service while in the area. But it's very hard to get a clear, accurate picture from that, but we do the best that we can. Then we look at the visiting specialists and the telehealth as well and make a decision, and generally our recruitment plan is based on a 3-year term. So of course noting that there can be many changes within those 3 years.
And maybe Mayor Cox, I can build on that piece a little. So the workforce plan, as Deb's commenting on, is something that's iterative. Part of what we're actually working through now is actually refreshing our workforce plan. So that actually then involves, again, connecting in with different local leaders and different physician groups. In some in some communities, it's specifically meeting with clinic owners to be able to identify, and asking the clinic owners, so what do you see as, the needs in the particular area? What do you see are some of the key things that we would need to be able to address? It's having those conversations. And one of the reasons why we thought it was going to be important for Stacey to join us tonight is High Prairie is one of our first communities in the North Zone that actually has community participative teams. And so it actually is a group that slightly different than when Reeve Matthews actually chairs an HAC and they deal with more strategic healthcare issues. The community participative teams actually get into some of the specific nuts and bolts and participate on, well, what about this and what about that? And that's very much what they're designed to be. So, we would be, again, gathering input from communities as to, well, what are you thinking? And that's part of the involvement that we're looking to build into some of the ongoing processes. In some of the early work that we did in the early days, you got to start with something. And I would suggest that our processes are getting better and better. The connect in with, again, different key stakeholders is getting better. So a lot of the initial work came from actually the local physician leaders. This is now more, as we're entering and refreshing our current plan, is, for example, in Hinton, we've got several private clinic owners. So as we're refreshing the plan, we'll be meeting with them to, again, better understand, what do they see as, the physician resource needs in their community. I know our team is looking to do that same thing here in High Prairie with the Community Health and Wellness Clinic and with the High Prairie Medical Clinic. I don't know, Stacey, if you wanted to comment at all on the involvement of, communities, in some of that specific planning purposes, because, again, I know we've spoken here before, Mayor Cox, about the Community Health and Wellness Clinic, and that fundamentally in looking in, we needed a model whereby we could actually bring significantly more resources, interprofessional resources, into High Prairie to manage the chronic disease burden. So again, as said, if we look at the way that things have been managed in the past, we still have really, really high rates of chronic disease. And in looking in, we feel we need a far more robust team that would be coming. The size of this team is, again, very significant. We'd be looking at something where it's an annual multi-million-dollar investment coming from HS to build that team. And you're talking upwards of 30, 40 people on this team to really better meet the needs in the area. That also influences, it's not directly, I mentioned from the beginning, there's a bit of a tangent. It influences, how many physicians you need, depending on the additional support that you actually have that comes through the community. For us, though, we really want to make sure that we're building this with communities, the team with communities, rather than telling communities this is the way it absolutely has to be. And that's a chunk of the work that I know Stacey's been leading with the community participative team. And I believe Reed Matthews and yourself, Mayor Cox, you're on that amongst
And
a
Councillor
couple other
Stewart.
people. So I don't know, Stacey, if you want to comment on that.
Sure. And I want to acknowledge to those that do sit on the community participation team, and I know Barry's in the crowd as well. So we really do appreciate the input from the community, and I think really important that we tie how we build the interprofessional team, and it is tied to the community health and wellness clinic, but it is not exclusive to the patients that receive services at that clinic. It is a population-wide. We are here to serve the community of High Prairie specifically, and then also surrounding communities. So we do have members from local here, as well as some of our Indigenous and Aboriginal partners as well, so that they're at the table and we're able to plan for the broad health needs of the community. One of the things that we have worked through is talking about where we are in our current space and what team we can build into that space until we're able to move into the new site. And so what the community participation team has decided is that the community could really need some support in terms of chronic disease management. And so that'll be our first onboarding of staff, and staff complement, as Dr. Worry stated, the 30 to 40 individuals that will be part of this interprofessional team. And so that's who we're going to work at building on to the team. I know there's some conversations around diabetes management and how do we ensure early prevention promotion and tie that to the workforce plan for our physician workforce. The intent of this team is to support the health needs of the community and to support the needs of the physicians that are seeing clients and patients and families in this area, so that they get the care that they need, they get the follow-up that they need. And also the intent is that individuals can also self-refer and access these services independent of needing to see a physician as well. So we are really opening up health services to really be about a diverse community-based team and accessing and building the team around the needs that are articulated by community members, by patients who receive the services, and by surrounding communities as well.
And maybe I would just ask, because Dr. Ibach actually has been chairing our medical staff meetings here in High Prairie. So Rich, is there anything you'd want to highlight from conversations at medical staff meetings, on physician recruitment?
No, I think we've had a number of medical staff meetings since I've been here, and if I remember correctly, I think I came on board in the High Prairie area October of 2014. And, I think probably a lot of the work that has been accomplished through the medical staff meeting has, which includes, all physicians in the community, as well as Roxanne and Olive Sonico, certainly surrounds some of the operational issues that have been going on. It is a venue to be able to discuss those types of topics that include recruitment, that include physician resources and so forth. It's not something that's necessarily come up or that has been steered in our direction during those meetings. I think we're here for a reason, because there has been some gaps in discussion surrounding these types of issues, such as physician recruitment, physician resources, health resources in general for community. And certainly I think there have been some issues that have come up. I think because some of these issues have not been necessarily discussed through those other venues in the newspaper. We've seen them through the minister and so forth, and I think a lot of that stems from a lack of understanding in general. So I think we're certainly making strides to facilitate the communication, not only between the physician groups within the community, but with the community itself, as Kevin and Stacey have pointed out.
Okay.
So perhaps what I would ask Council Mayor Cox, if I could, is it isn't always a 1, 2, 3 sort of topic, and would just want to be able to check in with yourself and Reeve Matthews and Council. Are there particular areas that I could explain, or our team could explain a little more succinctly? Or were there particular early questions that came from Council with which we might be able to assist?
Okay, we will poll the council now. We'll start with Councillor Gilroy, and we'll go around, and each person will have a chance to ask questions and perhaps build on the one before them. So, Councillor Gilroy, if you want to say no comment, we can move to Councillor Stewart. And we'll come back to you for sure.
I'd enjoy if you came back to me later.
Councillor Stewart?
I just want to know if Dr. Laughlin's clinic gets the same opportunities as the wellness clinic.
Yeah, so I think that's an excellent question. It's a question that we've had come up. I know Reeve Matthews has raised it as well. So any of the clinics that are in town, when a physician is recruited to a community, and we've been very clear on this in High Prairie for several years now, that any physician coming has to see both clinics, so that both clinics have that same opportunity to go ahead and a physician can see it, and the physician can then choose where do they want to be able to operate their practice out of, where do they want to operate their business out of. It's a basic part of fairness from our perspective.
I would like to ask one other thing. I'm reading from a letter that Dr. Laughlin has said, and he's talking about some physicians that would like to come. We have already paid for a doctor to come and see High Prairie in the winter months, and he wants to come. He and his wife prefer small communities. Our request to AHS was rejected. We actually have 5 physicians who are interested in coming to High Prairie from South Africa, but we cannot hire even one, as AHS is refusing to allow them to come and to practice the readiness assessments. I should point out that these doctors are eligible according to the College of Physicians and Surgeons, who license doctors in the province, provided they're sponsored by a current medical clinic. And I'd like to hear your answer on that.
Sure. So a couple of things. Firstly, the High Prairie Medical Clinic can recruit as many fully licensed physicians as they would like to go ahead and recruit without any support, let alone any sort of interference from Alberta Health Services. So what I'm hearing in that, and again, I've heard something similar through media reports, is that there are physicians that the High Prairie Medical Clinic would like to recruit. And that's one of the reasons why, as Alberta Health Services, we specifically do want to be able to meet with the owners of the High Prairie Medical Clinic to better understand exactly what they would see as physician resource needs in High Prairie. So I've laid out, some of the ways that we would look at things for High Prairie. So, for example, some of the factors that we would typically look at in High Prairie, with a catchment population of around 12,000. With the recent recruitment of a GPA, so our family physician in anesthesia, it brings 8 physicians into the community. So when you look at, what does Alberta Health and primary care particularly look at for physician-patient attachment ratios, they're looking for something that's about 1 to 2,000. and we'd be sitting at 1 to 1,500. So certainly well under what the government is looking for in their attachment ratios. Additionally, some of the things that we look at, and again, I'm just providing broad strokes, is we'd be looking at, as Deb Whetstone was talking about, third next available appointments. So how challenging it is to come in and see, how hard is it for a physician, for a patient to get in and actually see their physician. And again, the mode of that number, so the most common number in High Prairie, with the data we've got most recently, is 3 days. Now, does that mean it's 3 days for every single physician? It absolutely does not. And we definitely notice in High Prairie, similar to multiple other rural communities, that our female physicians typically have longer wait times, so it takes longer to get in for routine appointments than it does to actually see our male physicians. But if we look at the most common time, you'd be looking at 3 days, knowing that urgent issues are actually seen same day. So what we would want to be able to do, Councillor Stewart, with what's identified in the letter is, I think that's the sort of stuff, and that's why Alberta Health Services has been making arrangements to actually meet with the owners of the High Prairie Medical Clinic to, again, better understand why they would like to go ahead and recruit additional physicians. Because that's part of the process. That's part of what we want to be able to do, and we want to make sure that they actually have input, that they're involved in that process.
Thank you for that. I thank you for that. I just want to make sure that they have every opportunity that the other clinic has, because I feel that is a freedom and it's a right of our people. And Dr. Laughlin's clinic has been here for many, many years and has served us long in loyalty. And I just want to make sure that he gets what he deserves.
No, understood. Certainly from our perspective, I mean, both Dr. Edwards, Dr. Laughlin are highly respected, long-standing members of our local medical community. They're needed, and we, again, we want them to continue to stay in practice in High Prairie. There's no question, there's no doubt in that in our minds.
Thank you.
Councillor Corley?
Just going to touch on this team of 40 you were talking about. Now, are you talking about a physical team of 40 people, professional people in our community that are going to be planted here in the hospital? Or are you talking 40 amongst the whole, from Edmonton on the way through?
Oh, gotcha. So what I was referring to is the composition of the community health and wellness team. Yeah. So here in High Prairie, right, that would actually be functioning out of the community health and wellness clinic in the new health complex. And I don't know, Stacey, if you wanted to comment on that.
Yeah, so these will be an interprofessional team, so they can be respiratory therapists, physiotherapists, nurses, chronic disease management specialists, which would typically be an RN, licensed practical nurses, and it just really, the complement of that team, that's why we give the 30 to 40, is going to be developed in conjunction with the community. And so instead of us saying, here's your complement, we have 35 bodies, this is what they're going to be, it's we have dollars to invest in the community, what are the health needs and how do we best meet that through the development of an interprofessional team, and they will be located here. And again, I just want to re-articulate that anyone in the community, regardless of where you doctor, who you doctor with, will have access to that interprofessional team. It is a community-wide, population-wide. We're looking at some outreach to our Aboriginal and Indigenous communities as well. It will be fully accessible to everyone in this local area.
Now, is that something that as soon as it's open, you have these people lined up, or is this a long-term, a couple-year program to try to put these people in place?
Yeah, so we've had the clinic up and running since December of 2014, I believe. And so we started then in terms of stabilizing some of the core health staff, and then we have now secured investment in terms of building up the interprofessional team. And so we've started having our last 2 meetings with the community participation team. We talked about the complement, and we're working over the summer here to start hiring some of that interprofessional team. And so we're hoping by by the time Christmas comes that we'll have a good majority of those those individuals onboarded. It'll depend on recruitment, absolutely, and it'll depend on you know, where we can have those up. Some of it too is dependent on our space right now, so we're looking at some more outreach, and then when we move into the new space, we'll be looking at more focused site-based team as well.
Thank you. Go ahead, Brian.
Councillor Panasic?
I've got all kinds of different questions here, so I don't want to monopolize anything, but I guess I'm really curious on how the private practices relate to, you know, AHS and the number of doctors and how that all figures in. And I'm still not really clear on, you know, if the High Prairie Medical Clinic or Dr. Loxon Clinics wants to hire somebody and bring them in, how does AHS prevent that, or why would they prevent that? And I got the impression that they are making it difficult for them to recruit. And I just want to clear that difference up.
Sure. So the question is how, what's the relationship between community clinics and Alberta Health Services?
Yes.
Community clinics, private clinics.
Yeah.
Private clinics. So typically the way it works now is private clinics, so a private community-based clinic can go ahead and bring in a fully licensed physician now without any support from Alberta Health Services, right? They can bring in as many physicians as they would like to that have full licenses right now. The College of Physicians and Surgeons back in May of 2015 decided that if a physician did not have a full license, and the majority of international medical graduates do not have a full license, then it actually does require Alberta Health Services sponsorship for it. So Alberta Health Services then does get involved. When Alberta Health Services has to sign off on a sponsorship, any of the physician recruitment, you know, that we would sponsor for a community overall has to be linked to the workforce plan and has to be consistent with the workforce plan. And that's different from if you are a private clinic in the community. So right now, if you're a private clinic in the community, right, you can bring in as many licensed physicians as you would like, and it has nothing to do with Alberta Health Services.
But what you're saying then is if they're not fully licensed, then Alberta Health Services has to sponsor them even if they're going to go to a private clinic. So you can prevent them from bringing in somebody to be able to work in a community, like the case in this situation where they have somebody that wants to come to our community and you guys are saying no because there's already enough doctors here.
Yeah, so again, I think there's going to be some details that we need to flush out directly with the High Prairie Medical Clinic, because again, I've read the media reports, but that's one of the reasons why we want to sit down, as Dr. Ibach was talking about, and actually talk directly to the High Prairie Clinic owners. So talk to Dr. Loughlin, talk to Dr. Edwards and say, okay, and we were hoping to have that meeting before tonight, but we weren't able to set up, so we'll do it after. But again, it's not a one-time meeting. We need to be able to do this on an ongoing basis, and it's also not selective to High Prairie. These same conversations are going on, you know, all across Alberta, right? And again, partly it's because there is a bit of a culture transformation, and the culture transformation with this change that the CPSA has made is in the past, you know, community clinics could bring in whatever doctors they wanted to bring in, and that process through multiple different levels has changed. Partly because of what the College of Physicians and Surgeons have done, partly because of what Service Canada has done, but there is now a push for more rigor as to if you're going to bring in a physician, and physicians typically cost, you know, they have a significant cost to the healthcare system. You know, there is an expectation from the healthcare system that we're using taxpayer dollars wisely. And so we have to make sure that when we're looking and building workforce plans and looking at, you know, how many chronic disease nurses do we need? How many physicians do we need? That we do look at those exact questions. And I think it's the reason why we do need to have that conversation with Dr. Loughlin, Dr. Edwards, and again, better understand exactly what they would see as some of the key needs in High Prairie. In the same way that I would describe some of the key things on broad overstroke that Alberta Health Services would look into, that we've discussed tonight.
Okay. if I got a couple more, if that's it's you talked about a 1 to 2,000 physician to population basis, and
Right.
I'm looking here that others are saying that ratio should be 1 to 1,000 to keep those wait times a little less to get in to see. So where did the 2,000 come from versus other experts are saying 1,000?
Yeah, so I don't know where 1,000 comes from. I can tell you that 1 to 2,000 comes from Alberta Health, so from the government. So that's the people that actually, again, oversee primary care.
Okay.
So they're the ones looking in to say, you know, what would you need to do? Again, though, one of the things that while ratios can give you an idea, it's the reason why we also watch, you know, how long does it take to get in? That's where we also look at third next available appointment. So we try to look at a variety of different things in managing pieces. The other piece that, again, is different now compared to 10 years ago is we're in a position now that a lot of the physician resource management is done by communities, as opposed, like by a community, like the community of High Prairie, as opposed to by private clinics. Right? And it's different that way. So for example, because a private clinic, again, functions as a business, as a private business, versus as a regional health authority, we look into the overall health services in the community, and we want input from the private businesses as well, so from the private clinics, right? But ultimately, it's a different process than what was there a decade ago. And again, this process for recruitment is all laid out in the medical staff bylaws, and any physician that chooses to work in an AHS facility agrees to follow the bylaws. In the same way that, you know, when the CPSA made a change in sponsorship, if you want to have a license to practice medicine in Alberta, you follow basically the guidelines that are set by the CPSA, and those are the same things that we follow in Alberta Health Services.
Okay, really quick one. Is a private clinic able to advertise on drjobs.com? Or is that only AHS?
So it's an Alberta Health Services website. So can a private clinic advertise on their own and recruit on their own fully licensed physicians? Absolutely, and many do. So many clinics absolutely advertise and recruit fully licensed physicians on their own and hire those fully licensed physicians.
But it would seem, you know, if there's one main site that where everybody could go, or every physician, and find both the private and the AHS ones, that would sort of even the playing field for everyone that way.
So so I guess what I would suggest is there is an even playing field, because AHS doesn't actually choose where a physician practices their business out of. We specifically stay out of that. So we look into, and we would identify what are the healthcare needs in a community, and then where the physician chooses to practice, and that's a business decision. That's that person's choice. But Dr. Jobs Alberta is specifically run by Alberta Health Services. There's other job websites that are out there.
Oh, okay. But if I've got the impression from the same letter that we're talking about that the doctors, the private clinics aren't given as much of an opportunity to recruit them to their side. They get half an hour to talk with them. Is there any guidelines on what they should get when somebody new comes into town or is considering this town, whether it's private or with a medicine clinic or the?
Yes, so typically if someone is going to come to a community and they're going to tour, we make sure that they're actually seeing any of the business options, right? Again, whether we're looking at High Prairie or Hinton or Grand Prairie, Fort Mac, we've got the same issues in all different communities, and we want people to see the different options. I would share, and I'm not sure if any of our recently recruited docs want to comment, but many physicians have a particular style of practice in which they want to work, right? They have a particular business arrangement they're looking for, and that's something they've already got in their mind when they're coming to a community. That becomes less of an issue, like in a community like St. Paul, where there's 5 private clinics. But when you've only really got one community clinic or one private clinic here in High Prairie, it can appear that there are differences, and it may just be because there's only one private clinic that's here, versus, as I said, in other communities there's multiple choices. And again, our push would be take a look at them all. We're not interested as the Regional Health Authority in dictating where you set up your business. But we do want to make sure that when you come to town, there's a need for that healthcare service and that it fits into the overall healthcare plan.
I'm sure some of my other questions will come up, but I'll let others ask them.
Thank you. Reed Matthews?
I have a couple. How much community involvement is put into your workforce plan each year?
Yeah, so I would say that it has, I would say it's a process and evolution similar to what Deb Whetstone commented on. What I mean by that is when we first started and we're getting things off the ground, a lot of the input actually came from our local physician leaders. What are you seeing? What do you think? Where do you think we need to go? Rough ratios like we've discussed here. Third next available appointments. What it's moving into is more of what we've discussed here tonight. And as Stacey's commented on, is the input we'd be getting from community participative teams. So overall, right, because physicians are, I'm a rural emerge doc, I don't mean to be disrespectful to physicians, but we're only one part of the healthcare system. So, and in many communities, the critical shortage is not actually in physicians, it's in chronic disease nurses or a dietitian or, another member of the healthcare team. So we would really be looking for the community's involvement in overall healthcare services. So we would see in High Prairie, and I think we're fortunate in High Prairie to be in that pilot with the community participative team, that's where a chunk of that input would come. So yourself and Mayor Cox and several councillors, several others here, that would be where the question would come. Well, what are we thinking? What input? Because we are looking for that involvement.
The second one, excuse me, how many health and wellness clinics do you have in the province outside of Slave Lake and High Prairie?
So the titling varies from place to place, right? I think one thing that Alberta Health is interested in is, can we clean up some of the titling? So really what we're looking at in either of these is you're looking at, co-located interprofessional teams working across extended hours. And again, yeah, you have that in High Prairie. Yes, we have that in Slave Lake. It's, again, processes that are being built in probably 3 or 4 other communities. And again, each zone is also a little different. So they've got community health clinics in other parts of the province. They're all a little different. What I would suggest is it's a model of care, Reed Matthews, that we see developing in more of our hubs or co-hubs, so where we've got these larger needs and where we have to be able to bring in specialty services. Under a North Zone title of either an FCC or a community health and wellness clinic, you've identified the 2 current communities, and we have several others that we're talking to at present.
That's everything for right now.
Okay, thanks.
My only question is, you're saying that you have a catchment area of 12,000. How do you arrive at that figure? Because I believe that our catchment area would be closer to 20,000.
Yeah, so typically what we do is we would look at some of it's called location allocation software. So it really looks at where people, based on their postal codes, based on their location, where they actually come to seek healthcare services. And so typically what we look at is what's the information we get from Alberta Health on that. So we go to multiple different sources. What's the information we get from, we have a part of Alberta Health Services called DIMER, and it really gets into the data and measurement areas. We get input from them as well. It was certainly one of the things that we looked at as we were looking at the new health center here. When we were providing population, and we had to build that over several years, the population estimates for that. So again, it's multiple different sources, but it's not unusual that we would come to communities and for some provision of services, the population served is larger than for others. So for example, the population may be larger for something outside of healthcare than it is for healthcare, or vice versa.
I would suggest you look at Statistics Canada that tells you the
Okay.
population of the communities.
That's a fair point, Mark Cox. That certainly, I mean, Statistics Canada is one of the places that we turn to as well. I think the area, so I don't think that we have a lot of challenges with populations of town proper or MD proper, we actually find that it's the catchment issue that becomes more contentious, where, you know, nearby communities say, well, that's not your population, that's our population. And, you know, they come here. And so when we talk about geographic, you know, location allocation software, they actually try to look at where do people actually go, rather than, okay, what's our rough estimate? So that's how we've often had to do some of the calculations when we do capital projects, or some of the service planning that Stacy and her team look at as she oversees program performance for the North Zone. But we can certainly take that away.
Okay, I will forward information on populations of First Nations and META settlements, which are usually vastly underestimated by both the provincial and federal governments.
Gotcha, thank you.
Councillor Danaka?
Based on your, what did you call it, your service plan to deal with issues that are in a community, it seems like a few of our issues have been falling on deaf ears in terms of dialysis, and in terms of you know, having chemo in the new hospital as well. Now, I don't know if it's the population that you're looking at doesn't justify that, or you don't have crude hard numbers that say we have this many people who can benefit from having this in the hospital. I'm not sure why there's such a disparity with what we're saying and what you're telling us.
Councillor Danaka, that really moves towards the second portion of our meeting, where it is a general question. Okay. But certainly will be a second question from the second portion of the meeting.
Sounds good.
All right. Yeah. Councillor Rose?
I have a few questions, and one of them is just further to what Mayor Cox said about our catchment area. Because in 2014, when you were here, Kevin, I think you alluded to the fact that we had about a 15,000 population catchment area, and even at that time I thought it was low. And you said that we needed about 11 physicians. And today I hear you say we need 8 physicians and we have 12,000. So where did that data change?
Sure. So I mean, the comment I would make is as we look at information, I think the more recent stuff that I'd seen out of some of our facility planning was again between 12 and 13. It was between 12 and 13,000 was some of the numbers we'd seen. 12,000 was a number that I'd recently seen in you know, a letter from Reed Matthews, and so that was one of the things that I was turning to. But again, when we look at catchment, we've seen high 1,100, so we look at 1,200. We've seen others that would say 1,300. That, I think, is what we look at the ballpark. You do make a good point as to when we look at, you know, how many people are, you know, how many physicians are we going to need in the end in High Prairie. I wouldn't want to suggest tonight that, you know, we have all of the physicians that we're ever going to need in High Prairie. I don't think AHS is trying to suggest that. I think what we would suggest is, you know, this is where we are now. There's still additional work that has to be figured out. So, for example, we're still in a position that we would have to be able to pin down, you know, how are we going to make sure that we're able to provide extended hours of service? Because providing extended hours of service for the community, actually, again, that takes additional resources, and often for that to work well, you need you know, people that are independent care providers or independent practitioners. In some areas, that's actually worked well as part of a larger team when you have nurse practitioners or you have other people that work as part of an interprofessional team. But again, I think that's something that for High Prairie is still in evolution, and I really don't want to take away from the work that's got to come out of the community participative team as they're figuring out what do they think those pieces as being. I was simply sharing what are the early numbers that we have used in stabilizing physician services. What are the processes we look at for what we need in High Prairie? I really do believe that the conversations we need to have with the High Prairie Medical Clinic, the conversations that the community participative team needs to have, are going to be fundamental in some next steps.
Is Peerless, Whitefish, and Trout Lake part of that catchment area?
So let me look. I probably would have to check that
Okay.
particular stuff for you.
Yeah,
I don't
wouldn't-
want to
wouldn't
give you
mind
something
finding out, because I
inaccurate.
heard that they're part of Slave Lakes, but I know that they use our facilities, and that they, like, so I know, and I hear you on how difficult it is to sort of track that information down, but it goes to that whole question of we really do need to find out how many people are using the services in the area and make sure that we're properly staffed to
Yes.
handle that, right? I just have another question, and I'm still confused about licensed, non-licensed doctors and who can hire, who has sort of the freedom to hire whoever. So a licensed doctor basically means somebody who's got a license in Alberta or in Canada, more or less. Is that normally our pool of licensed doctors that we have freedom to hire, or that any clinic has freedom to hire?
Yeah, so typically a physician that has, that is Canadian trained, right, is in a position, or, has been in Canada for a period of time. So you typically move from, again, it's CPSA nomenclature, so from a provisional registrar into the general registrar. And once you have a general license, then often you have the opportunity, but to move province to province. Again, that varies province to province.
So there's no concern, there's no restriction over any clinic hiring any licensed doctor?
Right.
Right. But the concern is we don't have enough rural GPs in Canada, and is this why we're going to international doctors?
So
more or less, is this sort of the concern, and is that why Alberta Health Services holds sort of the restriction on international doctors, because it's more easy to get an international doctor to come to a rural area?
Yeah, so I would say that we attempt to do many things, from how are we actually building our own Albertan grads, because, and not...
That's a whole other thing that needs to be fixed.
Right. So that's one of the things we continue to work on with the University of Alberta and the University of Calgary. So there's a PNME program. How do you get people into, that are already in second year medicine, how do you get them involved? There's an ICC program, so in fourth year, how are you getting them out to the rural areas? There is Rural Alberta North programs in Grand Prairie, in Fort Mac, right? So we've been successful in the last couple of years in getting that family medicine program off the ground in Fort Mac. We're trying to build more and more. What can we actually do and build within Alberta? Those physicians in graduating, again, they have a full license. They can practice wherever they would like to practice. Again, it was a college decision, so a College of Physicians and Surgeons decision in May of last year, to indicate that if you don't have a full license and you're coming in as an international medical graduate, that the sponsorship would be, it could only come from Alberta Health Services. That's different than what was there before, but that's the new regulation that's in place. My impression, and I'm not in a position to speak for the College of Physicians and Surgeons, but my impression is that overall, government is looking to make sure that how we use our physician resources matches where people are indicating the needs truly are. Physicians tend to be a very expensive resource, and we would want to make sure at a time that healthcare costs only appear to be climbing, that we're making sure that we have our docs where we need them, but also, do we have the right people involved? So for example, again, if you go back 10, 15 years, really the model of providing care in many communities was hire as many docs as you could. And that was your only solution. We know that in a community like High Prairie, that will not go ahead and give us the turnaround in some of the real challenges we have, like having the fourth highest chronic disease burden. We know in the literature, and again, we spend a lot of time working with our Provincial Center of Excellence, so our provincial primary care team and Dr. Richard Luanchuk, and looking in to say, well, if this is what it's showing, if this is what the people of High Prairie are going through, what do we need to do a better job? And again, his team's looking in conjunction with Alberta Health, and those were the conversations in 2013-14. You need to build this much more robust interprofessional team. It won't be something small. Something small really won't get into what's needed. You're going to need, again, different models of care that I know Stacey and her team are exploring and want to be able to further discuss with the community participative team. We're proposing in early phases, but we need to talk that with the community, bringing an Aboriginal healer as part of it. a chunk of the work having actually outreach chronic disease nurses that, as Mayor Cox is talking about, would actually work on some of the reserves, getting out to some of those areas, because that's the sort of stuff that we know actually helps turn around some of the challenges.
And I appreciate it, and I think that there's some really great ideas coming out of Alberta Health Services with looking at making some of the changes. Still confused about
Sure.
the international doctor versus, so you've talked about a workforce plan
Mhm.
that, for starters, who put that workforce plan in place? Like, did we have community involvement? Do we have local doctors here as part of telling Alberta Health Services their impression on what we need in the area?
Yeah, so, again, the workforce plan is iterative, so it develops over time. The initial phases of workforce planning, had input from our high prairie physicians. But again, I would want to be clear, that needs to be refreshed. I mean, I think as Dr. Ibach spoke of, I don't think it would shock anybody in the room here that not all physicians in high prairie agree on what do we need to do for physician resource planning. We need to be able to sit down with some of those key physicians and talk.
So there maybe hasn't been input by the key physicians in a recent.
So I would say, for example, again, when some of the work is initially done, I mean, we've got 5 new physicians in town now, right? So again, we would want to make sure that some of that input's there, but we also want to make sure the community participative team didn't exist when some of the initial workforce planning was taking place. We would want, again, input from the community on those pieces. And then again, that input goes up to the zonal clinical department, right? So that looks at as a zone, so the whole North Zone for rural family medicine, gathers that input to go, okay, again, based on that input, what's our advice for what we need to be doing in High Prairie? And that input then goes to the Zone Medical Administrative Committee, where, again, that's where the workforce plan actually comes for support. And then it's from that, if through that process, it's identified, well, you're going to need two additional physician postings in a community, be it High Prairie or another community, then again, those positions would be posted on drjobsalberta.com, and any physician can actually go ahead and apply for those positions. The person or the people, if there's 2 positions that are successful, then they would actually be going ahead and seeing both clinics and deciding where do you want to work, and that's ultimately where they would go to work.
I guess my question is has there been input from the High Prairie Medical Clinic on the workplace plan?
Right, so I guess what I'm saying is we're refreshing that plan now and specifically meeting with the High Prairie Medical Clinic, because previously there was input from our High Prairie physicians, but I don't believe that the approach that we took in the past was meeting with private clinic owners anywhere in North Zone. That's something new that we're looking at because of the CPSA change, which just happened last year, where now only AHS can do the sponsorship. We feel as a result, we need to make sure that we're talking to the clinic owners to go, what is your perspective? What are you seeing? What do you see as the local needs? Versus historically, the model would have been go to your community medical director, right? So go to your local physician leader, and as Dr. Ibach spoke of, you would bring it up at a medical staff meeting, you'd ask, you gather input, and that's how input was gathered. That's the historic model.
So just further to what Councillor Stewart
Sure.
was talking about, or you had mentioned to her that there was a meeting that you had tried to set up.
Oh, yeah. So that was
and
just.
has that been set up, or is that?
So I believe that that's what they're working at. But again, I want to be clear, this isn't a one-time meeting, right? So I wouldn't want it to come across to council that this is, say there is concern coming from the High Prairie Medical Clinic, we're going to meet with them once, and any issue is going to go away. This is on an ongoing basis. As we have workforce planning, we need to make sure, not just in High Prairie, but across our North Zone communities, right, as we've got community or private clinic owners that have perspectives and have input on physician recruitment, they need an opportunity to be involved. In the same way, what we're going to be pushing for, High Prairie is the first, that really has the community participative team. I'll be seeing if I can twist Stacey's arm to see how many more of these we can develop, because I really believe they bring a more robust input from communities, from patients, from families, from elected officials, from the HAC, from Indigenous populations. We really think that we need that as we're trying to plan healthcare together.
Okay, so I'm just going to wrap up my thought, which,
Sure.
which really, I'm still a little bit confused about the workforce plan, and that's why I was asking you, like, who was involved in the creation of it.
Sure.
So we have one in place here, right? And even though it needs to be maybe updated.
Sure.
But we can hire 10 doctors, any clinic can hire a number of doctors that are Canadian licensed or
Right.
licensed, and that doesn't affect our plan. So we don't go to our plan when it comes to licensed doctor, we only go to our plan when it comes to non-licensed doctors?
So I smile because many people would say exactly the same thing. I go and I'm just explaining what the rules are. And the rules right now, when the question says,
I just want to make sure I understood that right, because that's what it seems like, yeah.
is AHS going ahead and interfering with this? Again, AHS has no ability to influence, private community clinics that want to recruit fully licensed physicians. So they have the ability to go ahead and do that. Some people feel that that's wrong. Some people feel that any physician recruitment should have to be consistent with the workforce plan. That's just not what the rules are right now.
Okay, thanks very much.
Sure.
Councillor Gilroy.
I do have a couple questions now. You were talking about the College of Physicians. Now I know, my wife being a nurse, there's an overall body in Canada, but then specifically if she wants to work in Alberta, she had to go through CARNA. Right? And they have specific goals on how they hire people. Now, is it the same for physicians where they have the overall general license, however, then you have to go to the specific province and get your license to be approved by that part of the body of physicians and surgeons?
So yes and no, and I don't mean to make it complicated. There is a Medical Council of Canada that, again, as you're coming through either training here or coming in as a foreign trained physician, that you have to pass licensing, and that's a national piece. But without any doubt, the key piece is you have to have a license with the College of Physicians and Surgeons in Alberta. If I have a license, if I have my Medical Council of Canada, I've written the exams, I have the approval, I have my number, and I have a license here in Alberta, but I want to work in BC, I have to apply to the College of Physicians and Surgeons of BC to get a license there.
Okay, which is what I thought. So my question, part of it is that when you're looking at physician recruitment, you talked about the two Calgary medical schools, or Calgary and Edmonton, U of A and that.
Yeah.
The other part, you no offense to physicians come from other parts of the world,
Yeah.
but is AHS and the College of Physicians actually looking at the graduates from across Canada, Dalhousie and all the rest, to try and bridge some of the gap in there?
Yeah, so it's an excellent question, and I think Deb would be able to tell you that so we've got 3 full-time physician resource planners, and while their principal focus, on a quarterly basis is checking in with the residency program directors in Alberta, again, we don't want to be limited just to that, so there is the reach out to the other provinces as well to see, okay, how can we actually attract Canadian grads to our rural areas?
Okay. Secondly, from what I understand you were saying, yes, we do need physicians who are, GPs, but you're also going to be looking at specialists as well to be part of this new team, more than just physicians. I'm just wondering if, since a lot seem to be going back to the community health and wellness team, if Dr. Laughlin's group, or if they had brought in or got a physician who was from another country and able to do not just the general stuff, but met your special skill set that you're trying to develop in this multi-discipline team, would they be able to not only hire that person, but also the communication lines, would that be fully a solid communication line between the two?
Right.
Or are you specifically looking at these community health and wellness team members coming through the new community health and wellness organization that used to be Dr. DeToit's clinic?
So Probably two pieces in that. So when I spoke about some of the specialty services, that, for example, would be our most recent physician we've recruited. So the family medicine physician with the additional training in anesthesia, that would be one example of a family medicine subspecialty. Or, you know, again, our need for family med, someone that can actually do C-sections, right? And again, this is all leading to our work on how are we going to be managing obstetrics in High Prairie. I think as we look at the community health and wellness clinic, and, you know, a variety of different team members, you know, as Stacy was describing, so whether we're talking about chronic disease nurses, whether, you know, we're talking about dietitians, exercise therapists, those different pieces, you know, wherever a physician chooses to run their office out of, patients can actually access services, you know, in the community health and wellness clinic. So there, it wouldn't make any difference where the physician chooses to actually have their practice based. But again, if I jump back to, let's say we needed to recruit another family med anesthesia, right? So if we work through the workforce plan, the feedback from the local groups, the whole process we've talked about tonight was, hey, there's a need for that. It goes to ZMAC, it's supported. A posting goes up on drjobsalberta, right, .com. And that physician is successfully recruited to High Prairie. He meets with the High Prairie Medical Clinic and says, I would like to work here. Can he work there? Absolutely. Can he or she, you know, would his or her patients have access to the interprofessional team that's based out of the Community Health and Wellness Clinic because there'll be AHS staff? Absolutely they would. And that's a fundamental principle. So we can't allow, you know, where a physician chooses to practice for business reasons to interfere with full access to patient and family-centered care.
But is it, what I guess I'm looking at as well is the idea that if for example, and we have obviously the letter of someone who had wanted to come here, if they would have had this skill set, sub-skill set, one of those that would fit into one of the places you're looking for, and the person really wanted to work in that particular clinic, would they have colleague access, be considered really part of the whole team with when you're developing more that seems to be more based on the other clinic? Because I'm thinking general hospitals I've worked in over the years, it is not one overriding area. They almost have like a hospital team itself that you come in, say for example, I know at one point we were thinking possibly of having some surgeons coming from Grand Prairie. Would they have the same ability to just put their heads together and get the job done, is what I'm saying.
So that would certainly be our hope, and that's the desired end state we're looking for. Again, in being candid, have there been differences of opinion within, you know, our medical team on that? Yeah, one of the reasons why we want to be able to meet with the High Prairie Medical Clinic is not just in looking at what we have to do with, you know, physician recruitment, but it's answering the question that Reed Matthews asked me when we were at NADC, so the Northern Alberta Development Council. So what are you doing to help out, you know, some of our longest standing docs? And part of what we want to be able to do is we really do want to be able to understand what are they looking at from a physician recruitment perspective, but also how do we make sure on an ongoing basis that, you know, while we may disagree on some business issues, how do we make sure we work well together as a medical team and make it about patients and families? I personally have no doubt whatsoever that that's the priority of Dr. Laughlin and Dr. Edwards. I have no doubt. That's how they've acted for years. So I just want to make sure that those communication channels are open and that we're driving towards that cohesive medical staff.
Okay. The last question I had actually had to do with some of the postal codes. There have been times, postal codes, how you...
Oh, yes, sorry.
And this, in a sense, this is a little personal because there have been times with my young family that we have not been able to, due to staff shortages and different things, get the access at the current hospital. So we've actually gone to McLennan or Slave Lake, and I admit that publicly. Would my postal codes, having been served in Slave Lake or McLennan, counted for their stats, or would it be the fact that it's still High Prairie need, but we couldn't meet the need? And how would that work?
So again, I think as Deb Whetstone was describing it, it's not always straightforward. I would suggest that overall, when we look at that location allocation software, they would try to determine principally where do you go for care, and then from that, where do we need to be able to provide the services. But would it prevent you or your family getting services here in High Prairie? No, it should not. And what we would want to be able to do when we look at some of those larger numbers, as Mayor Cox has commented on, or catchment numbers, we really do want to make sure that overall we're meeting the healthcare needs of the area. We fully understand that there's going to be some things that, again, whether it's visiting specialists, whether it's telehealth, some specialty services. I mean, we're not going to be doing neurosurgery in High Prairie, right? And no one expects that. But we do understand that there's going to be some services that are more appropriate for people to travel for because we can't do them safely here, given the volume of cases that would come up. But overall, we want people that live in this area to be able to actually get the care that they need in this area.
But if for example, I'm being served in Slave Lake or McLennan because the lines are too large or different reasons, and once again, it's not a slight against the staff we have at our hospital, but if such a thing happens, my postal code means that there wasn't the need, there wasn't these resources here to serve my need. So I had to go somewhere else.
Right.
I didn't want to go somewhere else. I wanted to have everything done in this community. And so I believe that postal code idea, you almost need to go to those co-hubs and say, okay, how many people are actually coming from outside because for one reason or another, they're not able to get the resources done or the services done in your community. And so hopefully, I'm hoping with the new hospital, trips will not have to be made out. That we will have on both clinics enough resources and in the hospital itself working together as one team to meet the needs of this community so we don't have to go other places. And that's more of why I want to see the work done here.
So I can comment on some of our planning that we do. So when we look at catchment population planning for service delivery, we look service by service. So one of the things, and I won't get into too much detail, but they're called commitment indices and relevance indices. And so we look at how many people access the services that are available in their community and how many go elsewhere for that service. And then that causes us a bunch of questions that we need to ask ourselves. So if it's emergency department care, we look at, so what are the types of visits that are going elsewhere, not just that it was an emergency department visit and we're going to hive you off and send you off to McLennan because that's where you went, but talking about what types of services did you receive there. And there may be something like if there's IV therapy, that's not, maybe you had to go somewhere else for that, or if there's a subspecialty in that department, that would get hived off. So it lends us to ask more questions versus just automatically saying your postal code goes there. And we have to talk about, is there patient choice in that? Like, do people want to go elsewhere? And we've had that in communities where there's been a program and they actually opt to go elsewhere because that's their choice. There's other times we've sat down with communities and they went for other reasons, and so we have to suss out what that looks like. And that's where part of the catchment, I think what Dr. Worry's talking about, is really understanding and getting input from the community. So not just looking at our data and saying, oh, this is what happens, and we assume what the reasons for that, but actually having a conversation with the community. And so anytime we run some of that data, we run through a list of questions around why and what other data do we need to get to really understand. And that includes community data. It also includes diagnostic data, includes demographic data. And so oftentimes we can then pull a group together that we know is representative of that young family, or maybe it's a different demographic group, and have those conversations. And so that just helps us suss it out. It's not always just really black and white in terms of your postal code, and then we hive you off and we plan for you over here.
Okay, thank you, Doctor. Thank you, Councillor Gilroy, for your questions. Thank you for AHS. I'll go once more around the council table. Then I would ask if there are any questions from the High Prairie Medical Clinic. This would be your opportunity. And then I would like to close this portion of the meeting and move towards an open discussion from the gallery. So, Councillor Stewart.
Well, I guess my main thing is we went 40 years backwards in this hospital. We used to have major surgery, babies were born, CAT scans, ultrasounds, everything. And we have doctors on both sides that are very, very capable of doing many of these things and are not able to do it. And I think that you're not listening to the people. Bureaucrats in Edmonton are making decisions that when they should be asking the people and the doctors from this community what the needs are and how many doctors we need. Not bureaucrats that sit in ivory towers and really don't know what our community needs. That's my opinion.
And I'm sure it'll be taken under advisement. The Community Participation Partnership Team, you can bring it forward there again. It appears from the conversations about the CPT that this team is seems to have more power than we originally anticipated, and I'm certainly sure we'll be putting lots of input into it now. Councillor Courtney.
I just had one more kind of just a wrap up, just to get my mind around on the recruitment. So anybody coming out of the universities in Alberta, physician-wise, they have the immediate choice to go anywhere. They have the golden ticket. They can go anywhere. Correct. So I want to touch on incentives. Did you not say in the initial intro that there is a certain amount of incentive to come to the rural area?
Yeah, so I don't think I did comment on incentives tonight, but can speak to it. I mean, typically.
Okay, let me rephrase that. Is there incentives to come to the rural then?
So there is, and again, what we try to do is we try to look at, again, what are the needs in a particular community. We also then try to weigh in, how great is that need? Is this a regular recruitment? So is this someone's retired? We've got, 20 people in town, one person's retiring. Okay, well, that's a normal turnover. Are we in a position that, geez, you've only got 2 docs in town and one's leaving? Well, that's a critical recruitment. You're not going to keep anything going. You're not going to keep an ED open if you've only got 1 doc in town. And so depending on the situation, so depending on the relative need, then we actually provide financial incentives linked to a return in service agreement.
Okay, that's where I was going. Is it's just a dollar figure, or is it a tax break, or is it like, is there? I'm just curious why there isn't a super flood of youth coming out of the schools that want to locate up here, because we haven't seen it. Everything we've seen is from what our local doctors have brought in from other countries, which of course there's issues with the licensing and being from out of country, right? So my next question is there anything happening to streamline that difference between out of country and our locals?
So if I'm understanding the question, are there things that we're doing to try to go ahead and produce more physicians in Alberta that actually want to work in rural areas?
Sure.
So there are. Would we like to actually see that moving along quicker? Yes. So some of the particular steps we're trying to take now is, again, it's working with the University of Alberta in particular on how we can further expand the family medicine residency programs that we have in the north. So in Grand Prairie and Fort Mac. So based on our numbers, we feel that there would be value in significantly increasing the number of people that would go through there. So you'd easily add, 10 positions. And in general, people that are going through the rural training programs, 70% of them statistically stay rural. And we're one of 3 rural zones, and we typically end up with about a third of them. And that's the reason why we need to be able to build more capacity for people to be able to go through. Part of that involves funding for education. so that there's actually more education spots available, so that some of our conversations with government and some of our conversations with the University of Alberta, some of our conversations as well with the University of Alberta is the relative openness to decrease the number of urban train spots and increase the number of rural train spots. So no net increase in cost, but we would have more people trained in our rural areas. The one thing that I think it's important for me to also highlight, you know, the vast majority of our physicians in the north, you know, at this point are actually coming from other countries. And, you know, I would have to say that by far overall the quality of care that we get, you know, from our physicians, because there's quite a rigorous screening process, is excellent. And I wouldn't want council or our community to think that if you see an Albertan trained physician, are you inherently going to get better quality of care than if you're actually seeing someone who is trained elsewhere. The whole reason why there's the evaluation process is a privileging process, and there's multiple steps, there's multiple checks and balances, is it should not matter where you're coming from. When you are an Albertan licensed and privileged physician, you are an Alberta licensed and privileged physician, and our community members should expect the same level of care from you.
Don't get me wrong, I really do think that our foreign doctors that have come in are awesome, and I'm really appreciative of them, but I'd like to see that path, a better path to come through, right? So, secondly, this high quality team of 40, what's our high quality team number right now in our facility?
Yeah, so what we did initially was we stabilized the medical clinic, so we have clerical staff and then the physician group that we've done some recruitment. So I believe we're at about 8 staff, and Trina can correct me if I'm wrong. So so this would be the 40 or the 30 to 40 would include the staff that we have there currently, and then we would be enhancing that complement.
Okay, so you figure about 8 right now, so it's 8 to 40.
Yeah.
That's the increase that we're gonna see.
Correct.
Now is that 8 including Dr. Laughlin, Dr. Edwards, and that is
This is just for the community health and wellness
I
clinic.
see.
Yeah,
Okay.
so that does not include. So
that's
we
what
would
I mean
just,
by a team. Like, is that
Yeah.
the overall team?
So it's the team that would be located out of the community health and wellness clinic, but again, that team will be accessible by anyone, regardless of where you doctor. So if you decide that you select to have a physician that practices elsewhere, you can still access that team. So that won't be a barrier to people accessing services there.
Okay, all right, thank you.
Just one thing, it's a small thing, but I'm just trying to get my head around the fact that doctors that are qualified, we have a certain number of doctors that we need in the town. Let's say it's 8 or 10. If they're all at a private practice and there's nobody in the family care, you would say, okay, well, we don't need any doctors in the family care center then. Is that correct? Because we have 10 doctors in the community, they're all in a private practice, this community is covered.
Yeah, so where the physicians choose to have their base of practice, they can absolutely make that choice. It wouldn't change the fact that overall a major addition in the interprofessional team is just that it's having all of those chronic disease nurses, the dietitians, you know, the respiratory therapist, the exercise therapist, the Aboriginal healer, you know, the reach. It's those team members that are fundamental additions to High Prairie that we haven't had before. And we really believe that based on the literature, it's a major reason why we continue to have the 4th highest chronic disease burden in all of Alberta.
No, I like the idea of the health, you know, the team approach and working on it, and I can see a lot of the benefits of that. But I guess I'm going back to some of the problems that you mentioned before, is if we have all of our doctors in a private clinic and they don't choose to work in the emergency department for a variety of reasons, how do we get that covered? Because my understanding is right now, any new doctors coming to the family care center have to agree to work part of the emergency department time.
Yeah, so one of the things that we wanted to do differently in setting up the community health and wellness clinic is historically, if people came to a rural community and you sign a return and service agreement, it would typically be linked to providing emergency coverage. It's typically for 3 years. And after 3 years, if you don't want to cover the emergency department, you don't have to cover the emergency department. Well, that puts us in a real pickle, because we can be in a position where we can't get critical coverage. So what we did differently in building the community health and wellness clinic is people that work in the community health and wellness clinic make an ongoing commitment as physicians to go ahead and work in the emergency department. And again, that was something that evolved as a core principle, because we really needed to make sure that we were going to be able to provide emergency services. And one of the reasons why it particularly came to light was when the community health and wellness clinic was being developed in 2014, again, we were struggling just to keep the ED open. And so again, it's very different. So private community practices don't have any obligation whatsoever to provide services in AHS facilities. They can go ahead and look after their patients in their community practice as they see fit, and they're overseen by the College of Physicians and Surgeons of Alberta. There's a number of other principles that we typically have followed as key components, principles that we believe in going ahead and building the community health and wellness clinic. And I would share with you, and I think it relates to Councillor Courtley's last question, that it is one of the reasons why some people choose to come to High Prairie. They look in at this interprofessional model of care, and they look at these more robust teams. They like the idea, some physicians like the idea of not having to run a practice, but in being part of a team where you can go in, you can do your clinical work, but you have a good chunk of additional supports. You're co-located with acute care. That's very attractive for a number of physicians that are looking for a different style of practice. And in many places, it's a newer style of practice. And that was one of the things that we also wanted to be able to provide in High Prairie, because we needed, we needed to be able to recruit high quality physicians here.
Okay, and just tied into that in the emergency thing, I've heard, and this is just general discussions, that part of the reason that some people do not want to go to rural communities is the fact that they're expected to do emergency room time, and lots of doctors may not feel comfortable in doing that type of a practice and dealing with those kinds of emergencies. Is that a factor in recruiting doctors to a small town? Have you heard that? Is that?
Yeah, so typically when we're looking to recruit physicians to any community, you have to match the physician's skill set and experience training with really the services you need. One of the reasons why we believe that we need to further expand the programs through the U of A and through U of C of training in rural areas is you need that additional exposure. I'm not convinced, and other people firmly disagree with me, I'm not convinced that the way some physicians are trained in urban areas fully prepares them for the challenges they see in rural areas. But I am convinced that when you actually get your training in rural areas, or you spend a significant chunk of your training in rural areas, you're far more likely to be prepared for what you're going to see, and that's ultimately, what we're looking for. Do we have some physicians that will go ahead and graduate, and again, they're looking for, quiet practices in a city? Yep, some want that, right? And again, I can't remember, someone used the phrase a golden ticket, right? So some people choose to do that. We need to make sure that the physicians that we bring to our rural communities are trained to manage what comes in the door, because we need to make sure that our communities are looked after.
Thank you.
Reed Matthews.
I don't have the numbers anymore, but I know that we talked about the Canadian graduates. And it wasn't that long ago, I know that between the graduates that actually go into GP practice, the ones that after graduation, the ones that decide to stay and specialize, the numbers that graduate for GP practice, but regardless of where they're going, do not replace the doctors that are retiring each and every year in this country. So to rely on the training of Canadian, given the numbers at the universities to train right now, you're not going to get rural doctors up to numbers by relying on Canadian training facilities. I'm very, I can't understand this, but I'll have to research it a little more, but the reason that only sponsorship by HS is allowed for doctors coming into the country by the College of Physicians is kind of really got a question mark in my mind about why they would do that, but I need to do a little more research on that one. And can I ask, is there one of your work plans for, say, a region like Canmore? Do you have one in all parts of the province?
Yeah, so there is. I'd be the first to say, as a zone medical director in the north, I don't know what that one is. So I could comment on somewhere else in the north zone if you wanted. I know those ones pretty well.
Because I've done a little research, and I know now these aren't all GPs, but I think there's 37 doctors, professionals in Canmore. 17, I think, are GPs, and the population there's 12,000 people. So the work plan there seems to have not worked out well for the rest of the province.
And again, I don't know what the workforce plan is there, but again, as has been mentioned, if you're Canadian trained, you get to choose where you want to work. So again, not sure if that's just a popular place to live and therefore that's where people want to work, or, sorry.
And I guess, and this is something I think you and I have discussed many times before, and that's, I think AHS is missing a huge opportunity in this hospital. We have the space here for a second operating theater. We again have the space for dialysis and for chemo treatment. And as my good friend George Keys often mentioned, for scheduled surgeries, scope work, ultrasound, all those things, it seems to be the same distance from Edmonton to High Prairie as it is from High Prairie to Edmonton. So if somebody needed the work done, there's no reason why they can't come to a center like High Prairie to get it done. And I'll guarantee the cost when you get here is going to be a lot less than if you go to the city. And that goes for Grand Prairie as well. Scheduled surgeries, all those things, there's no reason why they can't be done in this new hospital. And I think that again would attract the quality doctors you're looking for. They would come here for that reason. In fact, we know there's a team of surgeons willing to come here to do that, scheduled surgeries. And of course, along with that, the problem with people going out for those types of scheduled is the leakage that it costs for our local businesses, a huge loss. And the huge loss, or the huge burden that the people that have to do that traveling for those types of services take on. It's devastating to many families.
So we will bring that forward for the community participation team. Recruitment, do you have another?
And one more thing, can somebody give me the current numbers that are seeing in the emerge department here each day now on an average? Does anybody have that?
No.
I don't have the current numbers, but we can run reports and certainly send them out, for sure.
Because hopefully those are taken into account when you're determining wait times, et cetera, for doctors, because I know people that walk into either or clinic and say, we can't see you for 3 days or 4 days, where's their next stop? It's in emerge where they have to be seen. So, and I know, in fact, my daughter just did that not too long ago way down in High River. She couldn't get in to see a doctor, so she just walked into emergency. And I know a lot of people, that was a general practice here for years. So take those numbers into account when you're calculating wait times as well.
And it's a good point, Reed Matthews. We do that. So we in particular look at there's a CTAS scoring system that looks at the severity of someone's presentation. So typically the more primary care type issues are CTAS 4s and 5s. And so we do that as part of our physician workforce planning. We look at that community by community.
My only comment is I echo Reeve Matthews' comment regarding the college and physicians and surgeons giving away the sponsorship to Alberta Health Services. I'm actually surprised because isn't the College of Physicians and Surgeons a doctor-run organization? So why would they, just as a rhetorical question, why would they give away that aspect of their administrative capability to a department, to a government? I mean, this is their doctor-run organization, and now they are bowing to Alberta Health Services. So I'm quite surprised that issue happened, unless, of course, it was under duress. And I'll pass now to Councillor Tanaka, and also, Councillor Tanaka, I'm still aware that you have the issue of the diabetes and the dialysis and the chemotherapy for after this meeting.
In listening to you discuss the recruitment process, personally, I don't understand a lot of how it works. To me, a lot of it doesn't necessarily make sense in my head how the process works. But again, it's government and stuff. I just want that our needs and what the concerns are when they're brought up for recruitment and need of doctors is really listened to, and it's not, well, we have this workforce plan and this doesn't fit, so we're going with this.
So I guess my reply would be I absolutely agree. The idea is, and it's certainly one of the reasons why it's extremely valuable for us to be here with Joint Council tonight is we take away feedback. I wasn't looking at this as just an opportunity to go ahead and explain the physician resource planning process, but also as an opportunity to take feedback, take it away. There'll be more feedback that again comes from the community participative teams. Our meeting with the High Prairie Medical Clinic, it's again all of those pieces, and agree. I think that piece is important. It's the idea of the link that everybody feels. I mean, it's part of being a Canadian, the link to healthcare, and people want to be involved.
Councillor Rose?
Once upon a time, we were chatting about wages, and when we're talking about recruitment, that's probably one of the biggest issues, right? So when you explained to me how the new model for the community health clinic would work, the doctors would be paid wages and it wouldn't be fee for service. They wouldn't be paying rent at the facility at the clinic. It would be a Alberta Health Service owned clinic, and they'd be paid wages more as employees. Now, did I misunderstand that, or was because I believe that that's changed? When I've talked to people more recently, it sounds like it is fee for service.
So it is fee for service, and there's always the opportunity to kind of look at what's called an alternative remuneration plan or an ARP. And what that is that's an agreement in between physicians and Alberta Health. So Alberta Health is the payer for all physician services, not Alberta Health Services, but the government pays physicians for their services. And there's the opportunity to negotiate a particular plan for how physicians could be compensated for the services that they provide. And that is one of the things that's been discussed for the Community Health and Wellness Clinic. Again, I wouldn't say hired. These are not employees. So the physicians there are still independent contractors. Some physicians can be employees with Alberta Health Services. So for example, just some are, right? Our medical officers of health are typically employees. Many, however, have contractual arrangements with Alberta Health Services as independent contractors, and that's where we are right now.
So they're more like a private enterprise. They would be a private contract, and it would be negotiated, and it would be paid each one may be paid differently?
So any of the physicians that work in the community health and wellness clinic right now, they would be billing fee for service, and that payment again is made by, or that payment comes from Alberta Health, right? So that payment structure is the same as what would take place typically. My guess would be in the High Prairie Medical Clinic, where the physicians there most likely bill fee for service to Alberta Health for the services they provide.
So doctors are paid similarly at both clinics then?
So yes, and that they're billing fee for service at this point. Again, I would just want to say that the option of moving into something else is there, and it's been discussed at the Community Health and Wellness Clinic, because a number of physicians are interested in ARPs as they look at, again, more comprehensive team-based care. They like the opportunity to go ahead and spend more time with patients. A number of physicians don't like the fee-for-service system. It's typically something that, again, is very numbers driven. So you make more money in a fee-for-service system if you see more patients, unfortunately, regardless of the quality of the care you provide.
Mm-hmm. And that's why I thought that's why the system was going to be paid differently, because it was to attract doctors and physicians that may not want to work as many hours or bill as, or sort of, I guess, have to see so many patients and be driven by the fee-for-service model. But yeah, now I'm sort of confused about.
So I would say
how
in evolution, right? What we didn't want to do, because it can take time.
So it did change though from when it was originally discussed?
No. So it's it's in evolution in the sense that to build an alternative remuneration plan with Alberta Health can take quite some time. 18 months plus is not unusual. So it's, again, you'd want to be able to build your physician complement that would be working the community health and wellness clinic, see, what is their level of interest. ARPs are all voluntary, right, as to whether people would like to be part of that, and that's part of the conversation that will be taking place with our community health and wellness physicians.
Okay, and just one more question.
Sure.
Currently, are we meeting the needs of the community with the amount of doctors that we have? So are you looking for doctors in the community, or have we met the needs? Because I know the question at hand really is physician recruitment, and the fact that there's a doctor from an international doctor that would like to come to the community, and it seems to be that he may be being stopped by AHS.
Right, so again, because we haven't had that conversation with High Prairie Medical Clinic, I think that is what we need to flesh out more. So in general, when we look in with the numbers we've discussed here, we would look in and feel that the care provision that's taking place in High Prairie is very good. But, and it's a significant but, we really do need that input from our community participative team. We really do need that input from the High Prairie Medical Clinic on, okay, so, why do you feel that this is the right thing to do? So, and we feel that that's an important part of the process, again, specifically after the change that the CPSA put in place in 2015. Because now, again, if you're going to bring in a foreign trained physician in your private clinic, you have to go through Alberta Health Services. We then have to make sure that we're communicating with the private clinics and really understanding what's their opinion, what's their concerns, what are their thoughts.
All right, I would now ask that if there's any comments. Let's take can we take a 5-minute break, and then I'd like to hear from the High Prairie Medical Clinic if they have anything they'd like to say, and then we're going to go into a general discussion. Okay?